Roundtable, our session on very relevant issues, relevant not only for today, but always they are relevant. And today we have the reform in diagnostics of oncology diseases. And from the position of pathology, oncomorphology, we can look at this. Today in the morning we have already had the session regarding oncology. Our colleague will speak over Skype. Now we'll arrange our connection. I hope that we'll hear him and his lecture. And now, as I know he already can hear us, I can say the following.
Hear you, and we believe that your lecture will be all right, and we see you and your lecture, and we are waiting for our connection. And before we speak, sorry, but in Russian, some words about our round table.
Now I'm just, starting the conversation. I would like to give the introduction, the welcoming words of our chief specialist, Nikita Savyolov, chief freelance specialist in Oncopathology, Moscow Department of Health. Maybe you can say important welcoming words. Nikita, please. Dear colleagues, and Alex, thank you very much for this presentation. This roundtable will be dedicated to oncopathology, and it was arranged the same day as pathanatomy, and these topics will be related because oncopathology is the part of pathanatomy, and even my presentation will have something from that area. But the main idea of this roundtable is to show approaches to more accurate diagnostics, and then to give more special, more individual prescription to treatment. Also, today we have already agreed upon the mechanism how, through the help of Marco Quality Lab, we can conduct 2 rounds for oncology labs, and it will be a pilot. If experience is successful, we also can involve other organizations, and this new equipment within the framework of modernization come to us, and we should understand how this equipment works. Larissa will also speak about this in her presentation. So she will mention the approaches regarding quality control in immunohistochemical research, and also pharmacological companies invest in this, but also the city invests, and maybe this is more important than pharmacological companies. I believe that's a very interesting idea. Methods and mechanism can be the same, but the general impetus can be different, and motivation can be different. Our dear assistants, what about the connection? Is it good or not so good? We don't have much time. Now let's be active. The round table means also discussion, interaction, and that's why now I would like to give the floor to Larissa Zavalishina. Please, Larissa, you start. Professor Zavalishina will start, Department of Pathological Anatomy, Russian Medical Academy of Postgraduate Education, and then maybe we'll hear our foreign colleague. Good afternoon, dear colleagues. I thank the organizers for this invitation to participate in this remarkable session. I like how the conference is organized. I'm for the first time in this at this event. Thank you very much for the invitation. I would like to speak about very important issues. And there were a lot of sessions dedicated to this. We had a big session dedicated to new trends in treatment of oncology diseases. And there we discussed the following, that the diagnostics is essential for this. And also here we have to define different parameters of tumor. And then clinicians can personalize medicine. In many hospitals, this method works. I will speak about immunohistochemical methods, but this method is very complicated, and because of this, we have to control our work. As I have said already, the method is complicated, but in spite of the fact that during maybe 20 years in Russia we use this method, and in Moscow Moscow was the first to implement this method in medicine, practical medicine. So in Moscow we work already with this method for 10 years. So that's why we cannot apply the word routine regarding this method. This is a really complicated method. We use a lot of reagents, new reagents. We also have new methods of work and a lot of components. And these all components influence on our end result. And then also physicians can give the treatment. So you can see here pre-analytical period when we prepare the material for conducting the research, and so then there can be a lot of errors in the end result. Then analytical period and also immunohistochemical reaction, and now we have a lot of new equipment and well-automated instrumental platforms. It seems that human factor is practically not here, but you know, human factor still plays a big role. And when we work at the we work with the super equipment, it can give us positive results. And post-analytical phase, this is the phase linked with experience, skills of pathology anatomists. And here we can see the results. We can see the way how to do treatment. Now we should look at the protocols. And in separate labs, it's not possible to do. And this data was in the European System of Quality Control, Nordic research. You can see variability of protocols because we can change our phases of work, and so practically at any time regarding immunohistochemical reactions. That's why we should work at the protocols, and the protocols should be conducted not only inside of some department, but also we should have the structure which could help departments, pathological anatomy departments, to do this, conduct this work. And sometimes they need some particular protocols for work which can give the best results. For us, it's difficult to standardize all steps of our research, starting with pre-analytical, analytical stages, and interpretation stage. That's why such standardization regarding immunohistochemical work, analytical stage is optimum and is more realistic. And as I've shown to you, inside of separate labs, sometimes it's difficult to do. Extremely difficult to do. That's why we need external quality control when the results of pathological anatomy department are checked by an independent structure. And the task of this independent structure are not to punish somebody, but their main goals are to recommend the most optimum protocols to get optimum results for patients. And this was invented long ago because this is the issue of quality immunohistochemical research and immunohistochemical area appeared there earlier. In each country with well-developed medicine, there are internal quality controls. And the goals of these systems are to control labs' work and labs get from this system quality control advice and recommendations what protocols to use and also for new methods which are expanded. Now we do not have this system in Russia. Many labs. Not many labs, some labs from Russia participated in this European quality control system, Nordic system, but here we had a lot of challenges. And in this big country as Russia, we should have our own quality control system. That is why when at the faculty we discussed this issue, we decided the following. Since 2017, we decided to do preparatory work, and in 2018, on the initiative of Ministry of Healthcare, with the help of Russian Association of Pathological Anatomy, we arranged such a system. Actually, we also work in a standard mode for less than 2 years. Of course, there are some problems, and we conducted not so many rounds on evaluation, but now it's clear how to build up this work. The main principles which are in the system. These principles are very similar to what we've had in other countries. This is a voluntary participation, but in many countries it's obligatory, and if a particular lab is not participating, so a physician will not accept this result. And this is the payment of participation, of course, because material preparation takes a lot of time and effort. We also use the site to conduct each round. So the system of quality control represents so-called multi-blocks TMI medications, and there are several samples of different tissue with different levels of expressions of the same marker, and on them we can control the protocol which is used in the lab. All these results which we receive by labs are gathered, and the Council of Experts gives its assessments on the basis of the criteria which exists in other systems of quality control. And after receiving this assessment, each participant receives an individual response, and in this individual response it's written how and what we should correct in the particular work with some particular marker. Each participant is anonymous. All labs are encoded under some numbers, and there is only one technical specialist who can you know, see this information, what lab it is. So experts are anonymous, and also always the answer is general about each round. And the individual answers can be received only by labs which participate. So we want to make this participation more comfortable for labs and useful. On this slide, you can see the system of quality control, its site, and also electronic email. So on this site, there is the beginning and the end of rounds, what markers could be used. Also, there is a list of experts, and there is a big list in each round. Experts change, and experts of some particular round are not communicated to participants because we want this to be anonymous and independent. Now look at the algorithm of quality control round. First we choose the markers which will examine. Then we create TMA blocks and we create benchmarking medications. And then we send this to participants. In response to the information that the center started this round, participants should send their own protocols, because experts have to understand what protocols participants used and why participants received this result. We should understand how it was done. We can't just look at the glass and we, in this case, cannot give recommendations. After this, we have the Council of Experts who give their assessments. Each participant receives his own individual result, on the basis of which he can evaluate his work and understand what mistakes he has had and can try to understand them. These are criteria of medication assessment. The first two criteria, optimum and good coloring. It means that this medication can be used in clinical diagnostics if expert assessment says that coloring is burden or bad coloring. It means that this medication this cannot be used. So the medications which are in the lab look like this. You can see several circles, and these are the fragments cut out from different blocks with different levels of expression, different markers we study. And in the lab, you know, they are colored differently, and experts understand how it should be. So in the quality control center, first uses different systems of detection, antibodies and color, these blocks, and we know what medications with which antibodies it was used. Only after this, participants receive these medications and they color this along with their protocols. Participants submit applications, then color them, and then receive the individual result. It's like an individual answer. So this is like the assessment of participants, and then there are recommendations what participants should correct in the work of his lab. These results are strictly anonymous. Only participants can receive these results. Everything started in 2017 when we conducted first pilot rounds. We worked at the methodology and of this research, and the first rounds were conducted together with the main expert of quality control system, Nordic, which helped us to do this work. In 2017, we conducted the first rounds on cancer of breast cancer, and markers. There are two markers, and you can see that we have the receptors of estrogen, and only 74% of labs could see the results with the help of them.
So 25% had suboptimal results regarding the establishment of hormonal status that has been established for a quarter of a century. Same about HER2, but for HER2 the work is with the closed systems. So you can see that the good result was yielded in more than 80% of cases. For the estrogen receptors, various options are possible, various antibodies, various instrumental platforms. As a result, in the third laboratory, the result is unsatisfactory. That means that the work with specific diagnostic systems is not well organized and provides bad result for clinicists. In 2019, 2 rounds for breast cancer were organized and 2 rounds for pulmonary cancer. As the latter round was organized in December 2019, we are still waiting for the results, but I think that in January we will have those results available. As an example, one of the rounds for breast cancer that we had in 2019, you see how the laboratories receive materials on quality control and assessment. These are envelopes with instructions on work with database and the instructions about filling in the forms. The control glass looks like this. Here you can see that every sample of tissue has different properties. Only using such heterogeneous material we can evaluate the protocol and see that the protocol really reflects the essence of the tumor and can serve as a basis for prescribing treatment. Have a look once again about estrogen receptors. We see that once again the result is not optimal. We see that there is a wide percentage of cases when the result was just satisfactory, but actually we have quite a lot of bad results. With HER2 the situation is just a little bit better because these are closed protocols, closed tool platforms. So sometimes a person with small experience or little qualification just cannot influence the way the protocol is developing. Another necessary marker for breast cancer is Ki-67, and here you can see that the situation is unsatisfactory, but still overall it's not that bad. When Nordic started its work, they had also satisfactory results in 70-75% of the laboratories that participated in this quality system. But what's the most pleasant is that what we got over these 1.5 years shows that out of 12 organizations that took part once again in the quality control system and tested their work once again, when they got the advice that allowed them to improve their protocols, then 5 laboratories improved their results. And instead of unsatisfactory assessment, they got a satisfactory assessment. And yet another option, we started working on a digital round. This is quite important to assess the expression of markers such as PD-L1 in order to prescribe oncological drugs, and in these cases we use various markers that need to be assessed, the results need to be sent, and experts will then provide their evaluation, not just regarding the diagnosis but also regarding the result interpretation. As far as we know, it's quite difficult to do that for PD-L1. The Quality Control Center publishes the results of its work. The sources include the Archive of Pathology journal, and we also organized a webinar regarding the outcome of our round dedicated to the breast cancer. We hope that it will help us to develop a protocol, and we are dreaming that this quality control system will yield some benefit and will make our work more standard, and the clinicists will be able to base the results of treatment upon that. Thank you very much, Larissa. I think that it is indeed one of the keynote presentations today, and I presume that some questions will be in order, but in order to save some time, we would like to first listen to all the other presentations, and then we are going to have a discussion, listen to the questions, and our speakers will be able to answer them. So now I suggest our next speaker to take the floor. Head of Molecular Biology Laboratory, Irina Demidova. Thank you very much indeed for having invited me at this amazing roundtable. My education is not that of anatomic pathologist, but I feel quite free in this community because molecular diagnosis is an inalienable part of the diagnostic process in cancer. I would just like to remind that we are all working on the same tasks, that is to say, identify the optimal ways of treating our patients while identifying some particularities of those patients. First of all, we are identifying the hereditary cancers, we are identifying target therapies, and we are trying to include the new appearing tests into our work. Of course, that would have been impossible without our colleagues, pathologists, cytologists, and clinicists. Why do we need that? Hereditary mutations are quite widespread, as it turns out. One woman in 500 is a carrier of PRCA1 or 2 that increases the risk of ovarian and breast cancer significantly, but this also includes the cancer of pancreas, prostate, and stomach. So early detection is a way to effective treatment. So far it has not been developed sufficiently, but there is a lot of effort in this area. Another goal of our work is to identify genetical mutations for which target treatment has been developed. We know that this treatment allows for previously incurable patients to live quite long. There are also some diagnostic tests that help our colleagues to establish the diagnosis better. And also what we call liquid biopsies. These are non-invasive methods or use of physiological liquids to trace the progress of the disease during the treatment. It allows clinicists to control the patient treatment. I would just like to show you that this issue of prescribing target therapy is quite relevant. This is the graph of 2001 and 2006, but still it shows the major changes that took place in the years 2000 when the target treatment was developed. Before, most target treatments were chemical or hormone-based, and now we are speaking about a new generation of target medicines. Now we are using target medicines and immuno-oncology medicines, so the role of biomarkers is quite important. Here I'd like to show you the list of biomarkers that are being considered in our laboratory. In red you can see the genes that have a big significance for treatment, for prevention, or for tracing the progress of the disease. And I'd like to show you how the number of pieces of research increased over the existence of our laboratory. This year we've had almost 10,000 patients for PCR research, more than 1,000 for fish research, and also we now have high-performance sequencing. That's a novel method that allows to identify a big number of markers, which allows us to determine the biological nature of the tumor and identify the markers that can be useful for target treatment. I have to say that it's not a mere coincidence that there is more patients who are coming to identify genetical markers or who are referred by other doctors. Last year, the healthcare department of Moscow and the Moscow compulsory insurance fund included a number of genetical markers in the compulsory medical insurance system for tests on a hospital and outpatient basis. That made life easier for both patients and doctors because now it is covered by insurance. Here you can see the tests that are now included in the tariff agreement with the insurance system in Moscow. They can be performed for residents of other regions. It's just that they need to have a special referral that will be governed by interterritorial settlements. And this served as an impetus to significant growth in the number of patients. As an example, I'd like to show you how the source of funding structure changed. Here we compare the fourth quarter of 2018 with the first quarter of 2019. So you see that the compulsory medical insurance system covered half of the patients, and the number of patients increased twofold almost. Here we can see that the compulsory medical insurance funding allowed to increase the flows of patients with various diseases. So what happened in 2019 when conclusions were drawn? It turned out that 41% of patients were examined through compulsory medical insurance system. Of course, the number of tests is not the same as the number of patients, and there were 12,000 tests conducted for those patients, and there was another 1,000 fish tests. What are the most popular tests? First of all, the identification of BRAF gene, because they are widespread and can be found in a big number of cancers. Then the mutation of KRAS and RAS gene, MSI gene. It is related to the fact that this marker was included as an indication for a new generation of treatment, and the mutation of EGFR gene. This is quite a stable indicator. And to conclude, I'd like to say that as of today, genetical examination has become an inalienable part of cancer treatment and allows us to enhance the overall life expectancy and quality of life of our patients. We can use, for example, liquid biopsy or a small amount of DNA to determine the mutation status and to select an adequate treatment for our patients. Thank you. Thank you very much, Irina. As you mentioned you are feeling free among pathologists. Yes, indeed, molecular diagnosis, genetic diagnosis, histological diagnosis, and other methods have become integrated. It is all part of the diagnosis process, and our dream is to make the system even more comprehensive. And I hope that in Moscow, at least, we are going to ensure it in the cancer cluster that is being developed. And it's important that this be covered by the funds of compulsory medical insurance fund. We are indeed a comprehensive medical system, and I would now like to give the floor to Nikita Saviolov as a representative of this system. Dear colleagues, actually, it turned out that I have two presentations at two similar sessions, and there is a certain overlap between my two presentations. As far as I see, the audience here is a bit different, so I am going to make a more detailed comment upon some issues, and in some other cases I am going to make accents differently. Because if we speak about the development of oncopathological service, we should absolutely speak about how its structure is being seen. Now we are at the point where the future of Russia is determined by medical officials. I don't know whether it is good or bad. The professional community in our society traditionally has not have any access to taking political decisions, and even if we have some good ideas that get born in the community, we need to run by our authorities. It's not the case of all the countries, by the way. So what I would like to do now is to show how we see the system in future, and of course, we do participate in this process, and the more active our participation is, the better and the easier it will be to achieve balance between what we want and what the other stakeholders want. I'm going to comment on this slide briefly, as the context of this session is different from the previous one. So, of course, it is flattering that clinicists believe that we are the golden standard, and this is a very pleasant paradigm in contemporary oncology. However, we understand that pathological and anatomical diagnosis doesn't have 100% specificity and sensibility. It's not a golden standard, of course. It is clear that tests may identify an ill person as a healthy and vice versa. So nature has provided that there is no unambivalent solutions. We may have a theorem that is describing a certain phenomenon, but we can draw contradictory conclusions from this theorem. Otherwise, the description will not be complete. It is found even in mathematics. Since medicine is closer to art, the situation there is even worse. So this conscious that we are seen as a golden standard imposes some responsibility on us, and also shows us that our goals are more or less unattainable. I hope that we will have some time for discussion to speak more about that. We need to establish priorities well and understand clearly that we will never be able to work without mistakes. Every time we are going to identify some healthy patients as ill and vice versa. So mistake will always accompany us, and our ideal and main goal is to make similar mistakes at least.
And then, if we make mistakes, the same mistakes, it will mean that our data at least can be comparable. And here we are approaching our last topic, which we were offered to discuss at this roundtable: big data, their analysis with the help of AI, the role of AI. I think Vyacheslav also will speak something about this, the role of AI. And I can see the role of AI not only to replace a physician, but maybe the formula will make diagnosis. In this case, only those who wrote this formula will be responsible. But AI will come to our life quicker, not to replace people, but to analyze big data, which will generate every day, and also with some lab systems, with the emergence of digital path anatomy. So all these storages, and will accumulate needed big data, and systems will be able to replace us. But at present, we are far from these ideals, and we try to eat a dog, so to say, piece by piece. And we'll start this in 2020, and this is quality control. Labs are not ideal, but at least this quality control will allow to realize the principles of oscillologist in onco diagnostics. And then, if we want to understand how it changed in the same oscillograph through transparent media, we should have comparison. And these glasses, which are generated within the quality control, the benchmarking, these are not perfect medications. They are not in compliance with the principles of golden standard. They don't have 100% specificity and sensitivity. But still we don't have anything better than this comparison and benchmarking. And that's why this is like the first step towards standardization, and also to do something about contradictions. Now let's speak about volume of financing. If you did not visit the first part, so financing changed. It grew by 3.5 times, and this growth happened because of two major events: for operative materials. So routine histological research started to be paid, and these codes also. And also we have additional spectrum of molecular biological research, which were not paid by compulsory insurance. If immunochemical tests, lower codes could be paid as markers, immunohistological markers, but tariff on PDL1 10,450 rubles, and this is only to pay for reagents. If we speak about tests by antibodies on the platform of DAC, nobody can earn money on this, only to cover expenses without even payment to people who were participating in this research, in this test. Speaking about ALK, we have 7,200 tariff, and it's balanced because reagent part is only 50%, and this is not a bad one. So it proved to be a very important part. Earlier we could have only 2,700. Nobody tested PDL1. If only reagent costs 10,000, to get reimbursement of 2,700, impossible. It's not a working system. And now this tariffs emerged, and we could have 16,000 for PDL. But still, at least they can be beneficial, at least. and this will help us to proceed. And in the future, this is quite an important slide. Our Minister of Healthcare presented at one of our sessions, and I'm allowed to use it. And this is for me not only new tariffs, but only a new infrastructure of oncological diagnostics. And the basics of this infrastructure is that we defined 6 oncological hospitals, but only Hospital 62 is only oncological. Some others have also other departments like gynecology. Other hospitals have also general profile hospitals. This is Moscow Oncological Hospital 62, DKB of Pletnev, also number 1, Watkins Hospital number 40. All oncological cluster will be in Kommunarka region. So these are major 6 oncology hospitals, and not only Muscovites go there. And here we also have the scheme of layout of districts, but also outpatient department will be linked to this hospitals. Physicians will send patients only to their major oncological hospital, and this is logical because the city wants to control expenses, and in the future this patient within 2 weeks should go to the major hospital. There is the investigation Oncoconsilium. After this treatment is appointed optimum practice, optimum tactics, and then there is monitoring. These patients go to onco hospitals. This is transparent routine of patients, and it will be published, and this will shorten the periods of oncology patients for treatment. So suspicion and then specialized treatment. What did we have earlier? For example, when clinicists from different hospitals of general profile in districts started to combine all these treatments, but they had only surgical methods for oncology, no chemical therapy, no radiological therapies, and for some tumors we have a lot of other methods. These patients, they received therapy of the last century because clinicists could provide only surgical treatment for them, but chemotherapy, radiation therapy were not there because hospitals did not have this capacity. And this reform, maybe it's quite logical, but still it will have downsides. And one of the conclusion is that it seems that we create a transparent system of routing of patients, but will we shorten these periods in real life? Because they will go from the top by the organizers, and since March we'll conduct, we have to fulfill new decree, and periods will be shortened also for pathological anatomy diagnostics. I don't see here any officials, but we fought for these periods. So, for example, the period for histological research. Speaking about morphological research, for this we have 10 working days. For us it was an accomplishment because we can't provide a research within 3 working days, biopsy research and morphological. And but still periods are reduced. But the initial motivation was for oncological hospitals, but the decree will be general, and it will also influence upon other institutions, thanks God, there will be some correction. And there will be maybe some institutions which are in compliance with the new period, some others are not, but I suspect that it will be can be referred to others. I don't know how will work under these conditions. And one more thing, so maybe you paid attention to this. On this scheme, you can see there are more than 6 highlighted circles. When we processed big data, it became apparent that if we compare the volume of biopsies and surgeries in Moscow, and if we compare them with possibilities of 6 oncological hospitals, these volumes don't coincide, and the real volumes of surgeries and biopsy will be much higher than only 6 basic hospitals. But also we have oncological consiliums, and we have 5 more additional hospitals, and some oncological profile patients could go there if they don't cope with this flow. What 5 types? This is Bakhrushin Hospital. They have 3 profile: abdominal tumors of brain, oncomammology, BK24, oncoproctology, traditional for them, also 31, oncourology, and we will not, in 31 they will not conduct breast cancer, and Pushkar Hospital and Pirogova Hospital, oncourology. All patients will be in these major hospitals. And how long will this scheme work? 6+1 from the point of view of pathologic anatomic diagnostics. How can we? What can we do with molecular labs? So we don't have answers to this, but maybe now we invest a lot of money into new buildings in basic hospitals, oncological hospital #1, Botkin Hospital. Maybe they then can get this traffic, and in this case we'll have some additional. Or maybe this system will not cope with this flow of patients, and in March we'll have the reform, centralized help, oncological help, but we don't know what design it will have when it's realized to the full. This is quite an interesting slide. We have already discussed it. It is dedicated to quality problems. If we want to solve these issues, what do we have here? You know, I'm a chief specialist, and I went around 6 hospitals. I had to see how the equipment, because we have a problem in Moscow. The institutions should write off equipment if it's expired. And this equipment should not only be written off, but also utilize it. In compulsory, but the insurance utilization is not covered, and a lot of doctors did not write off equipment. And formally, it's still on the balance, but physically it doesn't work. In one of the clinic in Moscow, there are 40, and 7 work only. And they asked me, where are the others 33? So the officials were in horror. Maybe microtomes were stolen, but it's not clear what we can do with them in a house. And then the financing was centralized. So when I started to look at what happens with wiring with this pre-analytical stage, I discovered that many labs, as on this slide you can see there are several fragments and they are put in one cassette. And I had a question: why do people do this? There are two things why we should not do it. Firstly, it influences on quality. Quality worsens, and when we put three slices into three cassettes, we can have payment for three. But if in one, we can get money only for one. But some violate it, and you can have penalty. What? But we. Maybe we should not increase the expenses. This is quite a sad conclusion. In these labs, physically, there is no distal processor, no distal processors. And when I try to understand why they don't have this, because I knew that they were paid for. The modern system, which worked till 2019 in the Department of Ministry of Health, was the following. The chief doctor writes a note, some of the officials agree with this and send it to work. And then there are clerks who take what's on the balance and they take operations and understand that you have redundant number of equipment, you don't need new, and if nobody writes off this equipment, it means that the equipment is still in use. And then the chief physician fights for this, but maybe a person without medical background receive some kind of resolution on this. And then when I went around these labs, we formed a plan of procurement plan. If we don't have this centralized without routine, we can't have, we should have pre-analytical stage. In this case, we need to have not less than 15 additional disco processors. And how many machines should we have to solve this problem at the level of the city? Because the problem is enormous. Equipment is not written off. And maybe we should have this initiative to create the commission, to write off everything, and we should have some money for utilization. And this is difficult. And one more thing, I will still leave some time for discussion. I want our round table to have the title. Systems and measures to control quality of lab diagnostics. I mean also pathological diagnostics. There are several key factors to manage quality, but we randomly pay attention to this. Because if you read these items yourself, you will see that everywhere we speak not only about the processes but about people who are responsible for this or that stage of quality control. So who in the department writes a plan about quality improvement? How will do this? When the chief of department speaks with his senior lab, and he says that analytics quality should be increased, what should you do? Let's write an application to have spirits oftener. And if you change your spirits oftener, quality will improve. But there should be the strategy of quality control. It should be on paper. Of course, there will be more paper used, but still this bureaucratic stage is very important because then somebody will come to a pharmacy and she will not get what she needs, and a pharmacist will say to her, please come next month. And next month she will forget about this. Now, I tried to get this program from my lab assistant, but I failed to do this. It's very complicated. And secondly, management of personal qualification, not only to get a high category, but if we speak about different diagnostics of different processes.
Overall, there is a rule of peer-to-peer review. What is it? It's when someone is reviewing some material after another person and that first person doesn't know about that, and this is just part of routines of a medical unit. There should be a certain calendar of peer-to-peer review. For example, if there are experts in biopsy of breast or stomach, so that they exercise review over their colleagues, and that humiliates no one abroad. But in this country, it is considered not as reviewing, but as something biased. When we are speaking about multi-heads, they are not installed in the pathology departments of hospitals. This will probably be the case by 2020, although it is not sure. Another issue is to find people who would be following a multi-head, because already people are so loaded that they don't have time to do anything else. And you may ask me how to perform peer-to-peer review if we don't have enough people. So the staff shortage is a huge issue indeed. The parameters that we have testify to the following. In order for everything to work in the cancer departments, we may do just one thing. Separate those who perform diagnosis ante-mortem and post-mortem. But to do that, the number of people who do only diagnosis during life should not less than 14, taking into account how many people are covered by every cancer clinic. Taking into account the current staff shortage, we may need to increase the staff tenfold. So this problem will remain for at least 10 years, no matter what the health authorities want. It is just impossible because at least 14 persons in every one of the 6 cancer clinics should do during life diagnosis without doing any other pathological work. Another issue is writing standard operational procedures. They are virtually non-existent. The Rospotrebnadzor is now doing that. Standard operating procedures should usually be written for a particular hospital. The standard operational procedure should take into account the working day and also where information is taken from, who is taking some samples or information, how people are working with equipment, whether people are working in shifts or not. So there is a huge number of parameters to be taken into account. So a standard operational procedure or SOP is written for every particular hospital. In an SOP there are 2 essential components: the component of the person responsible for his performance and the component of accreditation of every new employee who is going to work according to this SOP. Ideally it should contain a list of questions for an expert who has never worked in this hospital but is an expert in histoprocessing, and after reading that SOP he should be able to work in this new place. As for external audit, fortunately we do have a quality control laboratory. Another important point is work with reclamations and feedback from clinicists and patients. Who is responsible in that for that in the department? Quite often patients say, I had HER in 3 places and the results were different. What's my actual result? There should be a separate person in every one of these 6 hospitals who is considering claims, including these ones, who will consider the protocols. The protocols of a neighboring clinic should be transparent for him, and he should be able to work with a neighboring hospital colleague to write an answer to this patient. As of today, we don't have normal practice of resolving the situation when the same test had different results in different clinics, and the patients sometimes write complaints to the president, to the court, and so on. I'm now going to move on to my final slide about the quality control system for the medium-sized laboratories. And by the way, all the Russian laboratories correspond to the American medium laboratories. We have nothing similar to a big laboratory. That is why I did not translate what they recommend for big laboratories. These are recommendations for medium-sized laboratories. So the laboratory should be presided by a head, and there should be a quality control director who should report to this head of laboratory. And there should be a branch of training. Training should be performed by a skilled professional who would be responsible for training quality control, for other things related to training. Another area of operation of a laboratory is working with claims. There should be a person who would be responsible for investigating into various claims. We have already mentioned that. This person should write SOPs and develop a plan of standardization events so that it is clear how to work with various materials. On this slide, you can see that we identified 2 persons. And by the way, what you can see here is a screenshot from WhatsApp. But unfortunately, there is nothing better than WhatsApp available today. We have 2 persons. One is responsible for quality control and histology, as well as pre-analytics. And there is another person, Anna Sharoon, who is responsible for immunohistochemical analysis. So here you can see one person asking a question to another to identify whether it is a concentrate that is used in the sample or not. And in a routine situation, if the doctor may make a diagnosis without resolving the quality issue, he will just establish the diagnosis and throw away the sample that is not good. He is not going to investigate in the whole chain. There should be a person dedicated who is going to work with that. He should receive a salary or a bonus for that. And in that case, people will refer all the issues to that person, so that this person could immediately resolve the issue. If there is some issue with the sample, a laboratory staff member should go to this person responsible for the quality control and report the issue to that person, so that the quality control responsible starts investigated. Also, there is the possibility to investigate and to check various hypotheses. Maybe the result is bad because the preparations were outdated or something else. So all such issues should be reported. And in order to do this, an optimal protocol needs to be developed. In that particular case, we should understand whether it is an outdated preparation or the antibodies that have become spoiled. Sometimes, although we have to control all this, we may overlook something and someone has to deal with these issues, and the doctor will never do that. And when there is the possibility to round the corners, so to say, he will do it, or he may establish a wrong diagnosis. So, now a couple of words about immunostainers. 6 cancer hospitals received immunostainers, Ventana XT and Link 48. You can basically overlook the figures written here because it's not the point. Why did we receive this equipment? So that our mistakes are standardized, so that our mistakes are similar, so that our HER diagnosis is brought to a common denominator, so that all kinds of diagnoses could be established in a uniform way to be able to prescribe the medicines. These platforms were selected to achieve precisely that. And finally, in order to move to big data and digitalization of our work, and also to create a tracking system, all the cancer clinics in 2020 will get a laboratory IT system, LabForce, integrated with the EMIAS system. And Anastasia Rakova said today that EMIAS will be the only system used in polyclinics of Moscow. So we are going to have good LabForce and suboptimal EMIAS that is constantly being upgraded. And I think that with the time it will be able to get improved, and we will be able to work there. But that will be the subject of a discussion. And by the way, we still have 15 minutes for discussion left. Thank you very much. I think that we have all appreciated this emotional speech by Nikita. And I'm very happy that we've had this emotional speech. I think that even experts were interested in having such detailed data, but unfortunately we are running out of time. Vyacheslav, as president of the Society of Oncopathologists of Russia, please be brief so that we have time for discussion. Dear colleagues, I'm happy to welcome you. I will be speaking without presentation and will serve as a bridge to our roundtable. I'd like to invite all of you to the 5th Annual Congress of Oncopathologists that will take place on April 24-25. So for 5 years we have been organizing open discussions. We have been discussing the issues of oncopathology, and we thus can see clearer the issues and the targets of our activities. This is the subject that we started to discuss, and it is bringing its fruit. It is finding response among colleagues, anatomic pathologists, genetics, and so on, as well as oncologists, because it is important for everyone, including cancer surgeons. And we see that it is interested in even at the administrative level. Nikita, for example, became an expert oncopathologist as a non-staff expert, although we understand that we have no such specialization. However, the issue is so important that it indeed requires a particular approach, and special attention needs to be paid to this. And we will continue paying a lot of attention to this issue because it is very important for cancer doctors, it's very important to be able to be based upon the data that we provide them with. And a lot has been said about the quality of the research that needs to be provided. And I wanted to make a compliment to Larissa and to the chair of pathological anatomy for the work that they are doing in order to implement the external quality control system. I took part in the quality control, such as Nordic, as a participant. That was financed by myself and by my organization. This year I took part in the quality control that was organized by you, and I did not see any particular difference between these cycles of assessment. I think that we also got the preparations, we got them stained. Fortunately, we got optimal results, which was also very important. I would like to learn what are the recommendations that you could give in order for them to get optimal solutions. What do you think about that? Now, regarding what we can do, I think that we need to continue talking about that. I think that we need to move forward. The subject that has been raised within this assembly, such as digitalization and artificial intelligence, I believe that these are the subjects that will indeed help us to make a step forward in spite of the fact that we do face a staff shortage and in spite of all the challenges that we are facing. Perhaps artificial intelligence could also help us to do our job, at least to some extent. But anyway, it's sure that digitalization could help us a lot. At least I see for myself the possibilities and opportunities, and I really wish that the department I'm working at develops digitalization. This year I wrote a request to get two performance scanners so that I could perform biopsies and histochemical tests, and I hope that it will be implemented and we will be able to speak about digital laboratories within the Department of Healthcare of Moscow. And I hope that it will allow us to get better results than private laboratories, since pathologists are working in a lot of pieces of research, and for them it's more difficult to get the necessary experience to diagnose cancers. So digitalization could help us to make a step forward in that respect. At the same time, it would allow us to get rid of many issues that we are facing when we are asking for medicines and preparations again, when we cannot get them, when the person has several cancers and no one has the necessary information. And digitalization would help us at the level of the country to resolve this issue. It would allow us to compare what was before with subsequent results. In some cases we would not repeat research and the materials that we already got would be sufficient. Maybe we would not redo some histochemical tests because we could use what's already available. Beyond any doubt, that would help in the work of everyone. So anyway, digitalization is something that in the upcoming 5 years will determine the development of our area and could make a real contribution to the Department of Healthcare of Moscow and its operations. So I would like to ask you to go on with the subject, to continue discussing it, not to be afraid to of spreading and implementing the system to make sure that scanners are available at every clinic so that we could look at the preparations of each other without asking the patient to go somewhere to make another test to show the result and so on. It will allow to streamline our work and reduce the time of diagnosis, because when a person comes to a consultation without any data, we cannot give him any answer. We have to wait for the results of the test, and digitalization could help us in that respect. It could help us to do our work quicker with a high level of quality. Everything will be in our field of view, and if we see everything at the same screen from all the sides, we will be able to see all the things that we have to see. That's what we have to explain to our management and resolve this issue as soon as possible. And in that case, we will be able to really improve diagnosis in this area. So I'd like to thank all the colleagues for being interested in this subject.
We should continue to do this with enthusiasm and interest to help patients to be healthy. Thank you very much.
Спасибо большое, Вячеслав Николаевич.
Thank you very much, Vyacheslav. Now I would like our colleagues to ask the questions. Please ask questions. Please, you're welcome. Take the mic. I have the following question as a customer. You know, as I understand, the federal medicine, Russian medicine, will be in isolation, and it will be the medicine of Department of Ministry of Health. So we are isolated of the federal system. This is a private state partnership. You know, yes, we understand this is good in the system, but if we have isolated systems, federal system is isolated and the other system is isolated, in this case it will not be combined. And how do you think about, what do you think about this? Whom do you answer? To the person who is responsible who represents the Department of Healthcare. MIA system is integrated into the Russian system, and at the plenary session we have heard about tough plans of the Russian system, and we as other specialists hope that the systems will be integrated. I did not really understand the question, but Vyacheslav, who arranges these issues, maybe he can add something. But for today, Moscow is a unique center where we have different structures, and of course, interaction is important. And this all is taken into account. But today we would like to launch urban and Russian systems. So they are integrated, and this is natural. Do my colleagues want to add something? I can answer. This integration already started. Money, so compulsory insurance money, city money, and we have federal quotes and city quotes. For example, Oncological Hospital of Blakhin received money, and city money, and quotes, and those this data, which we get as a result of computer tomography, patients receives this in the form of city EMIAS. If we need quotas, these centers should do integration, and then data goes directly, and then they can give patients discs to patients. and the city will do expansion of its digital systems, and that's why there will no be any isolation, and everything will be integrated with city digital systems. Thank you very much. I would like to add, I work in the Federal Center, and I can say, speaking about pathology and anatomy diagnostics, the Federal Center is not paid by the services rendered to Muscovites since the middle of this year. Moscow can fulfill these services by itself, on itself. And if we want to speak about our positions, whether they are close or not, now we still have all our own routes. And the federal centers and the Department of Healthcare of Moscow are different. Because the Department of Moscow is large, but mostly this is the regional structure. And the Federal Center has different tasks to help other regional departments. Moscow is so strong that maybe it does not need such help. And the main goal of these federal centers are to help regional oncology centers to increase the level of this help, to get it closer to those parameters which we can provide. That's why we go in one direction, but still. And I also have a similar question. I'm a patient, and I also I was treated in the federal centers. And I have this question, did I get you right that since summer of this year, the access to federal centers will not be possible? No, you got me wrong. I meant compulsory insurance. This is on the account of means of department. But this is all regulated at the level of territorial funds. So this is the question not to us. Because we reconsider this every year, and conditions are not changed. We started our year when the federal centers rendered diagnostics within the framework of this fund, and the second year we finalized already without this work. That's all. So this is changing every time. Does it mean, so when we create the system which you speak about, if I use the services of the federal center, I will not be forced to reconsider the results which are received in your labs? The medication reconsideration should be done by clinicists. Nobody here force you to do something. Maybe you need second opinion, or maybe physician can trust. And if physicians makes decisions, they look at the results, morphological results, whether they are in compliance with clinical picture. If there is compliance, it's okay. So everywhere we are patient-oriented, and this is their own issue, their own questions phrasing. Very good. Another question. We have still time, colleagues. If there are no any questions, as I understand, do you have still one question? Churchill said very well, you should be very careful about perfections if even they are dictated by common sense. I can't understand the role of general hospitals. Your system assumes that patients who come to outpatient clinic, he should go to your center. But as former specialist, I can say that 75%, 1 year ago, the primary diagnostics was conducted in general hospitals, emergency hospitalization. And then 2013, all IG hospitals had histoprocesses. Everybody has had histoprocesses. So everybody has this equipment. Then regarding pieces, here we have one problem. And it will be your task. So still we don't have the information about medical services, and we don't have the system of distribution of these pieces. And GoForm said that's okay, but insurance company, we can't understand what volume they want to pay for. So each insurance company will investigate, will invent its own number of material. Prostate adenoma, 100 pieces, quite difficult for payment. So we should solve this issue. And maybe we should initiate compulsory services on reconsideration. Thank you very much. Nikita, maybe this is the question to you. Prostate is a very complicated organ. There are many fragments. And if we pay for all 80 regarding labor, it's not fair. But as the head of the department, I disagree, because we still have some costs which are not covered by any tariffs. And these stories, when the fund paid too much, so the balance then is fine. That's why I think maybe this is not rational from the medical point of view, but regarding reconsideration, this is a huge problem, and it's very difficult to formalize it and standardize it. We had a lot of talks, and even we decided about the second opinion. We don't know in what form, but it's still not in the tariff agreement. Maybe now some reconsiderations will be paid, for which we need immunohistochemical research. In this case, we'll solve another problem. When patient comes with 58th form, without reconsideration, sometimes it's not rational to do. What classical error did we have last week in our department? When the 58th form and the block was already packed by clinicist, we defined LLK, so expression, tumor, modern recommendations, immunohistological method. The patient gets creatinine, no effect. Questions, patient come to understand what's happening. And clinicist receives all material, and long ago he did this biopsy already. We look at this biopsy, nobody used it, and there we can see that there is the same tumor the same structure as in the first, but there is another adenoma carcinoma. And if a patient did not respond to therapy, so the first material was not endocrine cancer. And neuroendocrine phenotype worked, and one of the expression not because of molecular increase. We check the story, color this material. The fragment of non-endocrine cancer is positive. We make markers. Then we want to clarify something. We fulfill tests, give results, not responsible. But then we started to understand it. We understood that this result. If we had this first research, we will never appoint LLK. Of course, we will not fulfill the Form 57. Maybe this year we'll have these reconsiderations, at least before these tests. And then we'll have some other reconsiderations. Insurance companies will get used to this, and they will pay for one more service. And this issue is being discussed, and we already have the mechanics how to do this even. Thank you very much, Nikita. This is a good example, but it's really very scary because in this case, a basic rule of pathology is violated. I'm not really so worried about tariffs now, but I'm worried about patients here. Economic discussions are not so important here, and you could not use the first material. Yes, I agree. Okay, you already answered, and I can comment on it. I have my own opinion. I want to realize what you have spoken about. There are certain rules, and these rules are created by people. And something new, what comes to us, is based on enormous experience, our experience and international experience. What Alex said, we cannot answer to this now, because this is a real problem. We'll never agree about figures 70%, even maybe 1%, maybe even one patient. But this pathological anatomy, I will comment on it. It means a copy of the whole healthcare system. There is the primary chain, outpatient, and the high specialized central chain, central part. And pathological anatomy is like the first front. And this is outpatient chain, not oncological. And patients will come there, or they will be brought there, and there. This is like the first row, the first meeting, and tumors can be seen at these meetings. I don't know patients who feel unwell go to specialized oncological centers. They will first go to general outpatient centers, healthcare centers. That's why we have to focus now more on if we now focus only on highly specialized oncological structures, it doesn't matter how many of them. But if we don't pay attention to the outpatient centers, if we don't have diagnostics, good diagnostics during the first visit of patients, in this case, there will be a lot of false sentence, and those patients who really have cancer will not go to this oncological centers. Sometimes the first biopsies also are sent to some departments which should not do this. And this is absolutely right. The means should not be scattered so much. There should be good level also of the primary diagnostics. And then the routines should be proper. I agree with my colleague. We have discussed this many times, and the rest, what we have heard here, this is a must. And of course, compulsory certification, quality control. We know fairly well how the level of work is different in different labs. And our colleagues mentioned this also. I can repeat what I heard in the morning at the session of pathology anatomy issues. Maybe we should change the name because pathology and anatomy is associated with you know what. We are pathologists. We are pathologists in Russia. And molecular biology, we are all together. We were happy when we opened hospital number 62, your lab. And this was done in order to create the one complex. So we spoke about systems of external certifications, but also internal control is essential. Without this, we can't work. And what do we believe in today? We have a chance, some kind of carte blanche or roadmap to change our stock work, which is not already in compliance with any modern things. We are stuck somewhere in the middle of 70s last century, when in Moscow we had only 30,000 biopsies, or 40,000. And now only for the city we have 3 million, but the same amount of physicians. We had modernization of equipment, but it was only once and not enough. I can say more if oncological centers, which you spoke about, I will let alone what we have in not oncological. But when
the clinic cannot do a biopsy because there is no cryostate in 2020, this is not serious at all. Today, in the morning session, we saw what is happening beyond Moscow, so we are happy at least that we have had this modernization, although it does not justify our passive position that we are going to further develop our service. The system of internal and external certification, I'd like to highlight once again, since this has been discussed at all the levels. It's all about staff and not just the quantity, the number of people. We need to change the plans of training. We have reached the level of State Duma and Ministry of Healthcare. We need to change the way we train our specialists, because 2 years of master's degree in pathology is not serious, so we need to understand how to finance that. This has to be resolved, and if we say that today we have 250 pathologists, anatomic pathologists in our system, and they are doing this huge amount of work that is more than any normal load. We should understand that any digitalization, any cloud technologies, anything that we might need will enhance the load. That is why, in order to implement these technologies, we need to work. I'm not now speaking about artificial intelligence, let us not forget that. I'm speaking about routine cloud technology and neural networks. What are cloud technologies? Who will be responsible for that? The units are overloaded. There are only 5 doctors instead of 20. And we just need a cloud technology. Doctors and medical personnel. Without them, we are nothing. Now this road is open, and many things will depend upon what we do now. It has been mentioned that this roadmap allows us to adapt. Changes will be made, and I was happy to hear that there is no rigid scheme where we can make a lot of mistakes. So, dear colleagues, I think that we can be quite optimistic in finishing our current session. Judging by the interest that it has raised, the issue is acute indeed. I'm grateful to all of our speakers. I'm grateful to all of those present here today, and I urge everyone, I urge all the stakeholders to take an active part in the work of the Society of Oncopathologists and anatomic pathologists, as well as other associations, because we will need to resolve those issues collectively. Thank you.